Okay, good evening everyone. So today I'll be talking about calcium channel blockers and its role in systemic hypertension. We all know that the systemic hypertension, which I'll be calling here as hypertension, millions of patients are suffering from systemic hypertension, and a large number of patients are not on optimum medical management. They should be as per standard guidelines. And a lot of patients therefore are not able to achieve the target blood pressure they should have, and that has a significant impact on cardiovascular disease, cardiovascular morbidities, mortalities, along with increased incidence of cerebrovascular accident, renal pathology, as well as ophthalmological complications. Therefore, controlling blood pressure with a proper antihypertensive regimen is very much important thing. Today, our main topic is about agilnidipine, the newer calcium channel blocker, which has several advantages over other calcium channel blocker. And we'll be talking about some points. These are, first of all, hypertension, its introduction. I'll say a few words about the epidemiology, the demographic parameters, then facts about hypertension in India, physiology of calcium channels, classification of different types of calcium channel blockers, place of calcium channel blockers in hypertension management. Then I'll brief you about agenodipine, mechanism of action, pharmacokinetics, clinical evidences, and the guideline recommendation. So, first of all, we all know about hypertension. Basically, it is a lifestyle disorder. It is a major risk factors for stroke, myocardial infarction, vascular disease, and chronic kidney disease. Globally, an estimated 26% of the world's population. This data has been collected from Circulation 2018. Therefore, in 2021, it is definitely quite high. And this amount of world's population has hypertension, and the prevalence is expected to increase to 29% by 2025. So, concern about Indian prevalence. Overall prevalence of hypertension in India was about 29.8%, as it was published in Journal of Hypertension in 2018. So the principal driver of cardiovascular disease in India is basically systemic hypertension, and 1 in every 3 Indian adults is affected by hypertension. In addition, there is low hypertension awareness regarding treatment and control status. Large number of Indians have pre-hypertension, which embraces the new stage 1 hypertension as per American guidelines. And Indians develop coronary heart disease at younger age, less than 40 years. We all know about these studies, irrespective of the geographic or expatriate status. So there is enough information that BP levels between 130 to 139 of 80 to 89 millimeter of mercury in the Indian subcontinent cause substantial cardiovascular disease, complications, stroke, and premature death. Therefore, it is very much imperative to control blood pressure to your targeted level. And now, physiology of calcium channels. I'm not going into details of this pharmacokinetics. However, you should remember that the calcium channels are several types. The L type and the T type and the N type. These are the most important of them that we'll be talking about today. L-type calcium channel blockers, main location are skeletal muscle, smooth muscle, heart, brain, and retina. And blocking of L-type calcium channel blocker results in dilatation of systemic vasculature, substantial reduction in blood pressure. T-type calcium channel blocker, which is present in heart, kidney, liver, brain, and nervous system. The advantageous effects in kidney function in chronic kidney disease, reduces proteinuria, and improves chances of kidney survival. In the heart, T channels play an important role in the pacemaker activity of sinoatrial and atrioventricular nodal tissues. Therefore, blocking these receptors definitely have some significant impact in the cardiovascular physiology. And the N-type calcium channel blocker, which is present in brain and nervous system, involved in reduction in vasoconstriction, heart rate, and aldosterone secretion. So, calcium channel blockers and their types are now quite familiar with us. And with this, I'll tell you the classification of calcium channel blockers. We broadly categorize into types: dihydropyridine and non-dihydropyridine. Dihydropyridine have greater selectivity for vascular smooth muscle than for myocardium, and it have less negative ionotropic activity. On the other hand, non-dihydropyridine have greater selectivity for myocardium than for vascular smooth muscle. So classification of dihydropyridine type of calcium channel blocker again can be classified according to first generation, which we all know about nifedipine. It's very well known drugs, very much useful in hypertensive emergency. Then came the benidipine, ifenadipine. Third generation were very popular amlodipine and agilendipine, which we'll be talking about today. And lastly, the tinidipine. So how CCBs has been evolved? Ill-type calcium channel blockers are widely used for the treatment of hypertension. The first generation drug nifedipine was clinically introduced in 1960. However, the drug activated sympathetic tone due to its rapid onset of vasodilator action, and which often results in reflex sympathetic overactivity and increased heart rate. That causes a significant problem whenever we are dealing with patients who are suffering from cardiovascular disease. The second generation partly allowed the reduction of sympathetic reflex by designing slow release formulation of the first generation drugs or by newly developing slow acting drugs. Later, amlodipine was introduced as a third generation, which exhibits a longer half-life in plasma than the second generation ones. And one thing you must remember, this is pharmacokinetics and pharmacodynamics improvement do not always evade the sympathetic reflex induced by hypertensive action of the L-type calcium channel blockers. And here's the importance of blocking the dual channel. So CCB, which target voltage-dependent calcium channels, are widely used in the field of hypertension therapy and placed in first-line therapy for hypertensive treatment by various guidelines. Traditional calcium channel blockers, including nifedipine and amlodipine, act predominantly on L-type calcium channels, whereas the novel CCB, such as agilendipine, inhibits both L-type and T-type calcium channels. In kidney, L-type CCB preferentially dilate afferent arterioles, whereas both LT-type and LN-type CCB potently dilate afferent as well as the efferent arterioles. And what is the effect? That results in decrease in the eGFR, decrease in the urinary albumin excretion. That gives a significant benefit in terms of nephropathic alteration. So this is the chart showing characteristic of CCB and their clinical significance. You can see the agilendipine has both action on L-type as well as T-type, and therefore the actions of the sympathetic nervous system, which results in increased pulse rate, is less commonly seen with this kind of CCB, which has a dual kind of mechanisms. The agilendipine has this benefit of not increasing the pulse rate when it is being used for treatment of hypertension. Evidence has also showed that the aldosterone contributes to endothelial dysfunction. We all know about ACE inhibitors, ARB, angiotensin receptor blockers that can give a significant cardiovascular benefit in this subgroup of patients. And increased aldosterone ultimately contributes to endothelial dysfunction, arterial hypertension, left ventricular hypertrophy, renal cell inflammation, and fibrosis. It has been seen that the T-type calcium channel blocking results into suppression of aldosterone secretion. So that is an added advantage with the use of agilendipine. So conventional CCBs including nifedipine, diltiazem, and amlodipine elicit marked increase in the GFR and renal blood flow by dilating the afferent arteries preferentially, whereby the glomerular hypertension and subsequent renal injury are expected to ensue unless systemic blood pressure is sufficiently controlled. LT-type CCB like agilendipine exerts vasodilator action on both afferent as well as efferent arteries, which subsequently reduces glomerular pressure, intraglomerular pressure, and ultimately reduces proteinuria, retards the progression of kidney disease, and improves overall kidney survival. Therefore, the agilendipine is a very unique calcium channel blocker. It's a long-acting dihydropyridine type of CCB, acts on both L and T type calcium channels. It has a strong affinity to vascular smooth muscles, therefore it is retained at cellular receptor even after clearance from blood. This continues to produce long-term antihypertensive effect, shows a gradual fall in BP, and does not induce reflex tachycardia. This is the mechanism of action. I have already told about blocking both L-type as well as T-type, therefore has a significant advantage and various mechanisms which ultimately controls not only blood pressure, also reduces the heart rate, at the same time gives a renoprotective effect. This is the advantage of agilendipine. So if we block both L and T type, then we will be gaining much more significant clinical impact apart from blocking only L type. This is a little bit pharmacokinetics. The dosage is 8 to 16 mg once daily. 16 mg is the standard dose for controlling systemic hypertension, which is comparable to 5 mg of amlodipine. Protein binding is approximately 90%. The one important factor is that it is being metabolized by cytochrome P450 system. Therefore, some drugs which has a significant impact on cytochrome system, this agenadipine should be used cautiously. THP is 16 to 28 hours. Fecal clearance is 63%. And regarding some specific populations that you should be worried, like hypersensitivity to any of the ingredients, should be a contraindication for use of agenadipine. Pregnant and nursing women who do not have sufficient data. Concomitant administration of systemic azole antifungal fluconazole, which can inhibit the cytochrome and increase the level, you should be cautious. Concomitant administration of HIV protease inhibitor atazanavir, which can inhibit again the cytochrome system, should be cautious about. Apart from that, erythromycin, digoxin, whenever we are using agenadipine, should be used very cautiously. So preclinical studies has clearly proven some important effects, that is the negative chronotropic effect, inhibit the aldosterone synthesis and secretion, dilate efferent arterioles, and preserves insulin signaling and glucose uptake. So these are the four important facts that the agenadipine gives over other CCBs. So what are the clinical evidences? I'll be talking about few trials and few studies. First of all is at-home study, blood pressure lowering effect of agenadipine. The objective was to evaluate the sustained BP lowering effect of agenadipine, and it was compared and followed for 16 weeks to the prospective observational study, and systolic blood pressure, diastolic blood pressure, as well as heart rate was monitored. And what you can see is that both home systolic blood pressure, diastolic blood pressure measured in the morning and evening decreased significantly by week 4 of agenadipine treatment, and the BP lowering effect improved to week 16, that is 4 months. So the conclusion of this study was that it have a sustained blood pressure lowering effect, and that lasts well into the morning of the next day, providing a 24-hour BP reduction. That is very important because the morning surge is very dangerous, which can cause cerebrovascular accident most of the time, along with increased incidence of myocardial infarction. So this 24 hours long-lasting effect and controlling the blood pressure in a particular same target level is very important. Apart from that, significant reduction in the morning BP, significant reduction in the heart rate. Therefore, agenadipine is very useful for treating patients with morning hypertension who are at high risk of CV events and high risk of stroke. So now I'll be talking about this study which has shown agenadipine versus amlodipine, and this study was followed for a very short period although, but it showed that when agenadipine and amlodipine both are used, and that the greater reduction of the systemic hypertension, greater reduction of the blood pressure was seen in agenadipine group compared to amlodipine. And once daily administration of agenadipine effectively controlled blood pressure and had a stable effect over 24 hours. Data suggests that agenadipine is an excellent antihypertensive agent and a good safety similar to amlodipine. And the lower adverse events of agenadipine was 7.3% compared to 10% in amlodipine. Not only blood pressure, we are worried about increase in the heart rate whenever we are using CCB. And this study, agenadipine versus amlodipine, a comparison of effects on ambulatory BP, also not only measured the significant reduction of systolic and diastolic blood pressure, also the heart rate changes. And it showed that both the drugs showed similar 24-hour hypertensive effect with decrease in SVP of approximately 13 mm of mercury. But when it comes to heart rate, that agenadipine decreased heart rate by 2 beats per minute, whereas amlodipine increased heart rate by 4 beats per minute. So that is a significant difference in terms of cardiovascular physiology whenever we are using agenadipine. Coming to renal protective effect, I've already told you this dual novel mechanism of action is very much effective in renal protection. And for that, this study utilizes measurement of liver type fatty acid binding protein and 8-hydroxyl 2-deoxyguanosine measurements, which actually a potential clinical biomarker used in monitoring and predicting the progression of chronic renal disease. And the aim of the study was to determine whether agenadipine and or amlodipine affected urinary protein excretion or the urinary levels of these parameters in 30 hypertensive patients with mild CKD. Study duration was 6 months, and you can see that this excretion in the adrenaline group was significantly lower. And the conclusion was that the urinary protein excretion, urinary 8 hydroxydeoxyguanosine, as well as urinary liver fatty acid binding protein levels decreased significantly in the adrenaline. In contrast, amlodipine showed a little effect on urinary protein excretion or the urinary levels of this parameter throughout the experimental period of the study. So both drugs exhibited comparable and significant effect on the SBP and DBP. However, the renoprotective effect in hypertensive patients with mild CKD was quite significant in the adrenaline group. And apart from that, it also decreased heart rate significantly, as we all know now by several studies. So now coming to agenodipine versus clonidipine, the fourth generation clonidipine, and this is the study which compared in different types of heart failure with ejection fraction. The studies are very small, but still the conclusion of several studies is that in patients with hypertension and heart failure with preserved ejection fraction compared to clonidipine, agenodipine improves the severity of heart failure, cardiac sympathetic nerve activity, and has a greater effect on aortic stiffness, leading to improvement of heart failure and cardiac function than clonidipine. And in diabetic nephropathic patients, the N-type calcium channel effects gets blunted. In these patients, T-type blocking action of agenodipine will show the benefits over there. So we all know about agenodipine and cardioprotection. In a crossover design, which was conducted in 21 hypertensive patients when treated with CCB other than agenodipine or venidipine, during the study period, the CCB was switched to either agenodipine 16 mg per day or venidipine 4 mg per day, administered alternately for 8 weeks. Agenodipine had greater beneficial effect on the autonomic function and has a greater beneficial effect on autonomic functions, and it has been seen to increase the baroreceptor activity, increase baroreceptor sensitivity, parasympathetic activity, decreases the sympathetic activity. These all are beneficial for reduction of the blood pressure. There are some additional studies that I will be saying in cases of adenylipine and CVD risk production, the IOTA study, which was shown uh, earlier in 2011, and it has clearly proven that the superior effects of the olmesartan and adenylipine therapy on central hemodynamics may be associated with more favorable cardiovascular outcome than with olmesartan and amlodipine combination. Maybe it is due to the decrease in the central aortic pressure, the aortic stiffness. So olmesartan in combination with adenylipine elicited a greater reduction in CBP and LVMI, left ventricular index, mortality index, compared with olmesartan in combination with amlodipine. Such different effects may be important for CV death and CV mortality. Regarding end organ protection in diabetic hypertensive patients, I have already said about the beneficial effects of adenylipine or urinary albumin excretion and carotid atherosclerosis. It has been seen that the use of adenylipine slows the carotid intimal medial thickness, which is very much important for prevention of cerebrovascular accident or stroke. And therefore, adenylipine and has a significant difference in terms of improved cardiovascular as well as cerebrovascular as well as renovascular physiology. Now, if we're talking about adenylipine and amlodipine and glucose tolerance and endothelial function, which is very important for development of subclinical atherosclerosis even in hyperglycemic or euglycemic or in the impaired fasting level. So this study was basically done to see this metabolic neutrality or metabolic beneficial effect of adenylipine or amlodipine. And it was shown that adenylipine significantly decreased the levels of glucose and insulin 2 hours after the 75-gram OGTT test. You can see in the chart, the red one is adenylipine and the middle one is for amlodipine, and the left side is for baseline. So the insulin sensitivity outcome as well as the glycemic status were basically improved with use of adenylipine. So after adenylipine, significantly decreased levels of glucose and insulin, and with a statistically significant p-value was found. Decreased serum levels of hsCRP was also found, and decreased interleukin 6, which is inflammatory marker, was also seen. So adenylipine treatment may have a beneficial effects against glucose intolerance, insulin sensitivity, the inflammatory state, and circulating numbers of progenitor cells in non-diabetic patients with essential hypertension. So effects of adenylipine on uric acid metabolism. This is the the last of this about the metabolic neutrality and metabolic beneficial effect of adrenaline. So apart from not only on the diabetic or non-diabetic with essential hypertension, adrenaline has a significant impact on the uric acid metabolism also. We all know that the hyperuricemia is not only a risk factor for gout and renal failure, but also an important risk factor for cardiovascular events and metabolic syndrome. And it has been seen that adrenaline significantly decreased SBP, DBP, and heart rate. Along with that, it has a decreased effect on the serum uric level and urinary urine to urea to urea creatinine in hyperuricemic patients with uric acid levels more than 7 mg per dl in males and more than 6 mg per dl in females. So adrenaline decreased the serum uric acid level, and this response was most prominent in hyperuricemic patients or patients with normal and overexcretion of uric acids. And effects of adrenaline on the hemodynamics of uric acid metabolism in hypertensive patients has been shown clearly in various studies. So putting guidelines into practice, we all know about the role of CCB, how important it is. We all know about the importance of AC inhibitors and ARB also. The patients who are suffering from diabetes with cardiovascular disease or non-diabetic with cardiovascular disease, we all know that the AC inhibitors and ARB are one of the mainstay, main cornerstone of therapy. However, it is almost most of the time that we cannot achieve the targeted blood pressure with AC and ARB. Therefore, we need the C, the calcium channel blockers. You may start with A plus B or A plus C or B plus C or A plus D. But C is the most important one. The calcium channel blocker is the C, and it is one of the most important drug which you must use to control the blood pressure. And if you are thinking about CCB, then you must be are thinking about adrenaline because apart from blood pressure control, systemic blood pressure, diastolic blood pressure, it has a significant impact on the heart rate lowering. Apart from that, it is metabolically beneficial in terms of glucose metabolism. It decreases uric acid level, and also it has a significant renoprotective effect. Apart from that, it has a strong anti-inflammatory effect also. In various studies, it has been found that it decreases these cyto-inflammatory cytokines and pro-inflammatory like TNF alpha, interleukin 6, and various other factors. And these are most important factors which ultimately leads to increased atherosclerosis and causing increased cardiovascular as well as cerebrovascular disease. Therefore, adrenaline has a significant beneficial effect in these systems compared to other CCB. So we all know about DSC guideline also that CCB is a class 1 treatment for the management of hypertension. And whenever we are thinking about CCB, we must be thinking about adrenaline. So lastly, I would like to summarize the whole discussion that the hypertension is a lifestyle disease and the major risk factors for stroke, myocardial infarction, vascular disease, and chronic kidney disease. CCBs are widely used as fast-line therapy for the management of hypertension. Agilendipine is a long-acting dihydropyridine CCB. It blocks both L-type and T-type calcium channels. Agilendipine elicits a gradual fall in BP, does not cause reflex tachycardia, has a sustained 24-hour BP reduction. It significantly reduces heart rate, reduces intracardiac pressure and proteinuria. Overall, offers BP control with cardiac protection and renal protection. With this, I thank you all, and I hope everybody stays safe in this COVID pandemic and stay safe, stay protected.